Hello and welcome everyone. Today's presentation is ICU acquired infections in immunocompromised patients. Recent decades have seen an increase in effective treatments for cancer, hematological malignancies, solid organ transplantations, and autoimmune diseases. This leads to an improved survival rates among patients with these conditions. Immunocompromised patients, due to their underlying condition and the treatment they are getting, account for a significant proportion of ICU admissions. Roughly one third of the ICU admission is because of these patients only. Reason for ICU admission among this patient is severe infection, immune mediated organ dysfunction, acute bleeding, and complication from the disease targeted therapies. Outcome from immunocompromised patient in ICU are influenced not just by their medical history and reason for the ICU admission, but also by their increased risk of acquiring new infection during the stay in the ICU. Now, the heightened risk stems from the baseline immune abnormalities, exposure to the broad spectrum antibiotics, use of invasive devices, and additional immune modulating therapies. The most common ICU-acquired infections in immunocompromised are ventilator-associated pneumonia, bloodstream infections. Particularly, they are vulnerable to opportunistic infections like bacteria with lower virulence, fungi, and viruses. A significant concern is the prevalence of antimicrobial resistance among these patients. Variability in the definition of immunosuppression across studies contributes to the differing reports on the incidence, microbiology, and outcome of ICU-acquired infections in immunocompromised population. Next is, what is the definition of immunosuppression and when can we say that this particular patient is immunosuppressed? It is defined as immune dysfunctions leading to an increased susceptibility to recurrent infection by both common pathogens and opportunistic microorganisms, which are as such typically harmless for healthy individuals. Now, the cause can be primarily inherited immune deficiencies, acquired conditions related to the cancer, hematological malignancy, and the treatment they receive for that. Organ transplants, exposure to steroids and other drugs, neutropenia, and HIV infections are other causes. Now, in critically ill, the literature shows that immunocompromised patients usually refers to those with at least one of the aforementioned conditions in the ICU admission. Now, questioning the immunocompetent label. The level of immunocompetent for patients without obvious signs of immune suppression is debatable, especially since conditions like sepsis can inhibit underlying immune dysfunctions. Now, conditions potentially impacting immune response suggest a hidden immunosuppression among patients not classically characterized as immunocompromised, with no diagnostic test available to assess the immune status in critically ill. This highlights the role of age and comorbidities in predisposing individuals to sepsis, with conditions like diabetes, cirrhosis, and COPD affecting the immune function. Patients deemed immunocompetent upon ICU admission can still be prone to infections by opportunistic organisms, indicating potential ICU-acquired immunosuppression. Now, ICU-acquired infections and can be profound, involving both quantitative and functional alteration in the immune cells, with several studies identifying pathophysiological mechanisms behind these changes. Now, immune markers. There is an emergence of biomarkers for stratifying the infection risk, including lymphopenia, HLA-DR expression on monocytes, immune functions test, though their limitation is they have not yet been used or they are not very available at the bedside at the current moment. ICU procedures and intervention, including the invasive procedures, certain medications, and blood products, have immunomodulatory effects which can further impair the anti-infective defenses. Preclinical studies have shown that normal microbiota influence the immune system development function, though its relevance in critical care again remains unconcerned. So, to summarize, what outlines is there are two types of immunosuppression, that is, the overt and there is a covert, indicating a range of factors contributing to the patient's immunosuppressive state. So, looking at the overt and covert, the overt immunosuppression can be primary, which is deficiency of the immune functions like antibody deficiency, cellular deficiency, combined deficiency, phagocytic defects, complement defects. Then there are chronic acquired immunodeficiencies like malignancies, hematological, solid tumors, transplant patients, patients on steroids, stem cell transplant, and HIV patients. But there is a covert immunosuppression which is going on in most of our ICU patients, that is, patients who acquire it acutely, like sepsis, viral pneumonias, trauma, surgery, brain hemorrhages, cardiac arrest, malaria, and there is a non-immune condition as such, like patient of diabetic, COPD, and cirrhosis, who are as such weak and their immune response is also poor. So, what are the mechanisms of infection in these population? So, mechanism is the factors include microbial balance, the nature and severity of the immune suppression, the disruption of the anatomical barrier, and the antimicrobial exposure. Now, coming first to the microbial factors, infections can arise by colonization of typical ICU bacteria or disruption of the normal flora, facilitating the pathogenic bacteria to grow. Pre and probiotics have shown mixed results in preventing infections like ventilator associated pneumonia. Now, there is a real scarcity of literature in this aspect. There is limited data on the microbiology of ICU acquired infections among immunocompromised, with studies focusing on the role of normal flora disruption and colonization by virulent strains. Now, immunocompromised patients are susceptible to infection by viruses, fungi, and atypical bacteria due to the reactivation of latent pathogens and environmental exposure to the ICU. Duration and severity of the immune suppression has an effect on the risk and type of ICU acquired infection, with certain conditions predisposing to specific type of infections, like prolonged neutropenia can predispose to fungal infection. Now, devices like catheters, tubes increase the infection risk, but recent studies challenge the assumption that immunocompromised patients are at higher risk of device-associated infections. Now, coming finally to the antimicrobial exposure. Prophylaxis can prevent specific infections like pneumocystis pneumonia, herpes simplex reactivation, but concerns exist about the role in antimicrobial resistance, especially when we are using broad spectrum antibiotics and antifungals. Selective digestive decontamination has shown to reduce the incidence of VAP and bacteremia, yet its impact on the antimicrobial resistance among immunocompromised, it's not something which has been well studied as of now. Now, overlap in the pathogen susceptibility. Immunocompromised patients often face multiple immunosuppressive factors, leading to susceptibility to a broad range of pathogens, complicating the association between specific immunosuppressive conditions and infection risks. The limitation of the current biomarkers is that they are unable to assess the state of immunosuppression of a patient as of now. So their functionality and diagnostic ability is severely limited. While prophylaxis is effective against specific infections, its association with increased resistance limits its recommendation, highlighting the need for more careful evaluation of antimicrobial usage in immunocompromised patients. So, coming first to the most important infection, that is ICU acquired bloodstream infection. Now, studies indicate that all-cause immunosuppression at ICU admission is not a significant risk factor of bloodstream infection in the ICU. Predominantly, it is caused by bacteria, that is coagulase negative staph, Enterococcus, Klebsiella, and Staph aureus frequently is associated. The proportion of gram-negative bacteria causing bloodstream infection seems to be increasing, and it is already very high in India. Blood cultures remains the gold standard to identify this. Rapid molecular assays have been developed but require prior culture incubation, and the direct use in whole blood is limited. Now, ICU acquired bloodstream infection is associated with increased mortality among critically ill, with immunosuppression potentially amplifying this risk. Now, initial empirical antibiotic treatment should consider individual risk factors for multi-drug resistant bacteria, the local ecology, the clinical severity, and the suspicion of candidemia. So, All these factors must be taken into account to decide your empirical factor. Just because the patient is immunocompromised, don't start an antibiotic. Broad spectrum antibiotics are commonly used initially with adjustment based on the susceptibility reports. Empirical antifungal is recommended if the suspecting candidemia with certain risk factors like prolonged neutropenia, a non-resolving fever, despite broad spectrum antibiotics. Therapeutic drug monitoring and de-escalation recommended for certain antibiotics to optimize efficacy and minimize toxicity. Prompt de-escalation is based on culture results, and clinical improvement is emphasized by antibiotic stewardship. Recent studies suggest that it may be safe to discontinue antibiotics in neutropenic patients who have been afebrile for several days and in whom no infection source has been found, contrary to the previous recommendation to wait for bone marrow recovery. Now, the lack of specific ICU-based bloodstream infection definition for immunocompromised makes the management a little difficult. So, the management guidelines apply to both immunocompromised and non-immunocompromised, highlighting the need for more tailored approaches with unique risks and need of the immunocompromised population. The next infection that we must have to read is the pneumonia or the respiratory tract infections. Studies have shown that the 28-day cumulative incidence of ventilator-associated LRTI is significantly lower in immunocompromised than in non-immunocompromised. Most ventilator-associated LRTI is caused in immunocompromised patients by the bacterial pathogens, predominantly gram-negative. MRSA accounts for a very small proportion of cases. The proportion of LRTI cases attribute to MDR is higher among immunocompromised, but the overall accumulation incidence of MDR is comparable with non-immunocompromised also. Now, regarding fungal and viral VAP, immunocompromised patients have a higher risk of these type of pneumonias with invasive pulmonary aspergillosis, a particular concern in ICU. There is no specific criteria again for diagnosing VAP and VAP-associated tracheobronchitis for immunocompromised patients. The same guidelines are followed. The diagnosis rely on the clinical signs, microbiological evidence, and for VAP, a new radiological infiltrate. Now, European guidelines favor fiber optic bronchoscopy with bronchoalveolar lavage for high quality samples, while American guidelines recommend endotracheal aspirates. Multiplex PCR panels have been endorsed for severe community acquired pneumonia but are less recommended for hospital acquired and ventilator acquired pneumonia due to limited targets. Current guidelines suggest immunosuppression as a risk factor for MDR bacteria in VAP and recommend broad spectrum antibiotics, including those active against Pseudomonas, for empirical treatment. The choice of empirical treatment in VAP in immunocompromised must be based on your local ecology and resistance pattern. The next is the incidence of antibiotic resistance in the critically ill. Now, immunocompromised patients are often considered at high risk of colonization with MDR, leading to guidelines recommending broad spectrum antibiotics. Now, suggesting a shift from MDR to difficult to treat to emphasize the clinical challenge to treating pathogens resistant to multi-antimicrobial agents. While studies have explored antimicrobial resistance burden, few focus specifically on the IC population compared with the non-immunocompromised and adjust for the confounders like antibiotic exposure. Initial associations between immunosuppression and antimicrobial resistance were not maintained after adjusting for the antibiotic exposure, indicating that prior and current antibiotic usage is the most important confounder over here. Now, the SIMDRIA study outcome shows that a lower incidence of ICU-acquired colonization with MDR among immunocompromised compared to non-immunocompromised, although the infection rate with the MDR are not significantly different. Now, studies finding comparable cumulative incidence of MDR between immunocompromised and non-immunocompromised patients. Now, antibiotic exposure, isolation measures, and the overall state of immunosuppression are among factors affecting the risk of MDR colonization, underscoring the need for further research to clarify the antimicrobial resistant dynamics in the immunocompromised. The next important thing we must learn is the viral infections. Now, this can stem from in-hospital acquisition or reactivation of latent viruses among patients who are immunocompromised. Now, common viruses in the ICU are the influenza, parainfluenza, metapneumonia, virus, coronavirus, adenovirus, respiratory syncytial virus, rhinovirus, and herpes family, with cytomegalo reactivation a very common incidence in immunocompromised patients. The diagnosis relies heavily on PCR-based tests, including multiplex assay for respiratory viruses with nasopharyngeal swabs and BAL sample as primary specimens. For suspected viral pneumonia, additional tests such as swab of skin lesions for herpes simplex virus and varicella zoster virus and quantitative PCR for CMV in plasma and BAL may be warranted. Empirical therapy may include coverage for the varicella zoster pneumonia with intravenous acyclovir in cases presenting as bilateral reticulonodular infiltrates with vesicular rashes. In CMV pneumonitis, especially in the post-transplant setup, ganciclovir is recommended with dose adjustment for the renal dysfunction. The use of steroids in viral pneumonia is debated except in the specific evidence of SARS-CoV-2. Persistent and relapsing viral diseases may indicate the issue of viral clearance or resistance to the treatment. The next thing that we must deal with is the invasive fungal infections. It is common in both immunocompromised as well as non-immunocompromised patients, especially the Candida and Aspergillus species. Now, defined by Candida species isolate from sterile areas, it can lead to candidemia and deep-seated candidiasis with risk factors being multi-site colonization and catheter-related infections. Now, non-albicans prevalence is increasing due to antifungal exposure, especially in patients with hematological malignancies. Mortality in such cases is around 50%. Treatment for invasive is antifungal and source control. Echinocandins are recommended initially with de-escalation to azoles whenever it is possible. Aspergillosis risk is because of the antifungal immunity, certain medical conditions like prolonged neutropenia, steroid usage, and severe viral pneumonia. Invasive pulmonary aspergillosis is classified based on the European criteria with diagnostic challenges in non-neutropenic critically ill patients. Recent extension of definition to include influenza associated pulmonary aspergillosis and COVID-19 associated pulmonary aspergillosis is also affecting our diagnosis. The IPA diagnosis employs a combination of clinical, radiological, and microbiological findings with aspergillosis culture from tracheobronchitis samples often used. The sensitivity of mycological biomarkers like galactomannan varies from patient conditions. So the treatment of this. The azoles such as voriconazole and isavuconazole are the first line, with emerging resistance to voriconazole being noted. Prophylactic antifungal treatment is recommended in very high risk patients, although benefit for other patient group is still unclear. Preventive measures like air filtration in ICU, prophylactic antifungal treatment with posaconazole for patients with high risk of invasive pulmonary aspergillosis. So what is the future line of research over here? Assessing the immune suppression challenge especially lies in a reliable, cost-effective method to assess the depth and type of immunosuppression. We just know that the patient is immunosuppressed. We don't know what is the severity of the immune suppression, what is the type of immune suppression. Now, current biomarkers are limited and the potential of transcriptomics needs more clinical evidence. Understanding the epidemiology, a clearer epidemiological picture of ICU-acquired infection in immunocompromised patient is needed, especially the risk factors, incidence, microbiology, and outcome to improve the prevention and treatment strategies. Investigating how the normal microbiota prevents ICU-acquired infection should open up new preventive strategies. Research should explore the mechanistic role of microbiota and the effectiveness of modulating this by pre-probiotics, fetal microbiota transplant, selective digestive decontamination through randomized trials. We must improve the diagnostic. The goal must be to go beyond traditional microbiological method to more faster and more accurate diagnostic methods. This should enhance the antimicrobial stewardship, leading to better patient outcome and reducing the community burden of the antimicrobial resistance. Immunosuppression biomarkers and immune stimulating therapies should help in identifying more biomarkers in this field and giving more precision-based therapy to the patient. Despite past failures in showing benefits in patient outcome, better diagnostic tools may help treat patients more likely to respond to such treatment and evaluate immunomodulating strategies more effectively. So, what is the take-home message from this? We must understand there are certain risk factors which prone the patient and make them immunocompromised. These are the baseline immune function, the disruption of the anatomical barrier because of the invasive procedures that are done in the ICU, the prophylactic antibiotic treatments that the patient are getting, making the organism more resistant, the immunomodulating therapies that are given in the ICU, especially the steroids, blood products, and other immunosuppressants, the past and present exposure to the microorganism, cross transmission from other patients, the environmental exposure, reactivation of latent viruses like herpes, and finally the colonization resistance of the normal microbiota makes the patient more vulnerable to infections. So, understanding the immunosuppression is very important. Recognizing the degree of immunosuppression at the time of immunosuppression may help us in tailoring the treatment strategy. Vigilance for infection signs, regular monitoring and early detection of infection is very important over here. Rapid and accurate diagnostic. Utilizing advanced diagnostics include PCR and biomarkers for timely and identification of pathogens, which is essential for detecting appropriate therapies. Empirical and targeted therapies like broad spectrum antibiotics, promptly adjusting based on the antimicrobial findings to combat pathogens, will minimize the risk of resistance. Infection control is very important. And finally, re-evaluation of the immunosuppression regimen must be done to assess the necessity of the ongoing immunosuppressive therapy, adjust to minimize the infection risk without compromising the baseline disease state management. And finally, implementing prevention strategies like upholding strict infection control practices, prophylactic treatment to reduce the infection risk in immunocompromised patients. Thank you for your patience.